These are my disclosures. So I was just going to talk briefly about how I think about these patients who are referred for, quote, pelvic congestion syndrome, and a nice paper written by a consortium of people with the AVLS talked about really renaming this to pelvic venous disease. And I think it's important, if you're going to treat these patients, that you understand their anatomy from the renal vein all the way down to the pelvic floor and into the legs before deciding what the best treatment options are. So in every patient, we do an MR venogram to look for iliac vein compression, renal vein compression, the direction of blood flow in the gonadal veins, the presence of varices, whether they're around the ovaries and the uterus or whether they're in the pelvic floor. And they've done a nice job in this SVP classification of breaking this into zone 1 by the kidney, zone 2 in the mid-pelvis, zone 3 is the pelvic floor, and zone 4 is the legs. And I think it's important to think about that. Dr. Razavi just talked to us about nutcracker. And in our practice, what we do is an initial consultation with a patient to ask a number of symptoms, get an MR venogram, and then our primary intervention usually consists of iliac vein stenting first, followed by gonadal vein embolization or pelvic floor embolization. If necessary, then we follow them back up and perform repeat intervention if needed. So when we first evaluate these patients, I think it's important to know everything on this list, both in terms of previous surgeries, endometriosis, lack of response to hormones, have they had endoscopies, cystoscopies. They tend to have symptoms from head to toe. Also, it's important to look for other midline compression syndromes. Do they have hypermobile EDS? Do they have median arcuate ligament syndrome that causes the upper abdominal pain? Nutcracker can also cause upper abdominal pain, food failure, nausea, vomiting, so can SMAS. And then a lot of these patients have postural tachycardia. Many of them have underlying mast cell activation, which is a histamine response that causes an inflammatory response, giving them skin changes as well as GI issues. If you don't stabilize the mast cells before you insult them with a procedure, these patients have a huge flare. And then we talked previously a little bit about what we do and don't know about metal allergies. The advantage of MRI, and we'll be publishing a study soon, over 50% of patients in one of our studies who had a normal appearance on CT, even for people looking for compression, had a significant stenosis on intravascular ultrasound. And I think CT grossly underestimates the amount of compression in patients. It also allows you to see the location of varices, but you have to learn how to read them yourself. They'll all be read incorrectly by the radiologists, unfortunately. And then it also helps us see alternative diagnoses that occur in the pelvic floor or in the organs of the pelvis. This is our MR protocol. I'm not going to go over it, but if anybody wants to take a picture, I get asked about it all the time. I think it's really helpful, and it's not a typical MRV protocol. This is what the TRIX image or a dynamic image can do for you. It can show you the direction of flow. It can only show you this in the left renal vein because there's contrast because the gonadal vein drains into the renal vein. The right drains into the IVC. So I see people all the time say there's no reflux in the right gonadal vein. You can't tell that on an MR. We give all of these quality of life surveys to our patients before and follow them after so that we can determine which symptoms are improving and what's happening with them. These are all validated quality of life surveys except for the ancillary symptom score, which has not been validated. I think Dr. Razavi did a nice job discussing nutcracker. I'll skip through that. I think some of the causes of pelvic pain associated with iliac vein compression are still under investigation or to try to identify the pathophysiology, but this is a patient with a severe iliac vein compression. We could see collateral drainage through the ascending lumbar vein and the presacral venous plexus, which in the middle picture, everything that's yellow is the nervous innervation of the pelvic floor, the bladder, and the bowel. So I don't think it's a huge stretch to imagine that elevated venous pressures in the pelvis could be contributing to symptoms in this area, as well as if you see where the autonomic nervous plexus lives on the right-hand side here, that's where a lot of the collateral venous drainage is, and we still have some work to do to figure that one out. This is a radiologist, actually, who had a DVT and had a covered stent graft placed, then had a balloon expanded stent placed. It kept going down because it was never all the way under the artery, and I was able to just ignore those, which I don't usually do, reline stents, but we had to, in her case, and stent through that, decompress this massive presacral plexus, but the patient came back after a year saying that she couldn't run her distances. She can't sit for 2 hours as a radiologist. She had severe right SI joint pain and left groin pain. pain. So I hear all the time that it's not on the basis of venous disease after we've done something like stent to decompress, but in patients with these large presacral veins, embolization of these presacral varices completely resolved all of her symptoms. She's asymptomatic now for 2 years and can sit and do her job, and she's back to running marathons. The bladder symptoms can come, I believe, either from the neurologic issues from obstruction or from varicose vein disease, but a lot of times I see people doing internal iliac venograms, and they're almost always in the posterior circulation. That's where the catheter naturally goes. It's hard to find the internal pudendal vein in the anterior circulation. It comes up high over the sacrum, and if you don't specifically catheterize it and image it, you will miss someone like this, for example, with varices outlining the entire bladder that can be easily treated with foam sclerotherapy, and I usually even add gel foam to that. This is a 73-year-old lady who's been symptomatic for years, lower extremity insufficiency, chronic pelvic pain, debilitating abdominal, bowel, and bladder symptoms, extensive GI and GU workup, severe low back pain. Nobody could find any cause, and she had pretty straightforward gonadal vein reflux with varices. I like to take the microcatheter all the way across the pelvis through the uterus into the varices on the other side and treat from there back with coils and foam. Really just treating the primary gonadal vein does not work in these patients. You really need to shut down all of their varices. Similar to in the legs, you often need sclerotherapy after a truncal treatment. And then in her, she had right-sided labial pain as well. And if we can get into that internal pudendal and see the dilated veins going down to the labia and treat that, she had a very remarkable response. So these patients come at any age and shape and size, and these procedures aren't super technically challenging, although some of the treatment of the pelvic floor veins off the internal iliac can be. I think the one thing we're missing is that in our practice, my sonographer started looking in the perineum in women who are complaining of vulvodynia and pelvic floor pain and would find these dilated veins in the labia and pelvic floor. And you can't see these from a superior approach, and often treating the superior veins alone does not decompress these. So we've developed a technique, which I know Patty's probably done this before. I know Kathy Gibson's done this, but it's not widely done commonly, which is just a direct needle access, 21 gauge needle under ultrasound guidance into these varices, performing a venogram, identifying these labial varices that often drain through the obturator, which is where I think their hip pain comes from. And you can perform sclerotherapy. Since there's air and foam, we can use that as a contrast agent and actually see where these are moving to. It can also help you identify the proximal leading branch to figure out how to get into that to coil the outflow if we need to. And these are just some examples. This is a patient with severe perirectal and anal pain after she'd had recurrent thromboses of stents, so they became covered stents, and she had poor drainage from the internal iliacs out of these stents, so we can do a direct access and foam those pelvic floor varices. This is a man. I'm starting to see tons more men with pelvic floor pain, erectile dysfunction, and penile pain that we can perform the same procedures on with foam and sclerosant. So I think in each patient that comes in with symptoms of pelvic venous insufficiency, we need to evaluate them for both compressive disease and reflux disease, not only in the classic gonadal vein and perovarian distribution, but also off the internal pudendal vein deep in the pelvic floor. And particularly in women who've had vaginal birth, we need to think about that birth trauma and the perineum.